All this is Dr. Mubeen Sayed from drbeen.com. I had promised that today we'll talk about phagocytosis and inflammation. However, there is another article which is really exciting and is very important for our continuing discussion about the durability of immunity. So I wanted to make sure that we can look at that as well before we go to the inflammation. So my apologies, but let's start this discussion. The basic study that was done in Iceland, and the study's purpose at that time was to look at the antibody production or presence of the antibodies in Icelandic population. From there was an article that looked at the same data, and then they inferred that the surveillance of a population is better done with antibody test compared to PCR test. And from there, when I inferred the data, what I found out, and they had talked about it in the article as well, that the antibody-based protection is not short-lived. And they have done the study over 4 months. So they said at least for 4 months, they can see the antibodies to be present. And there is a very decent explanation for that as well. So I thought it is important for us to see it. I have been saying it for about since 4 months now, that I believe just like SARS-CoV-1, the antibody-based protection or immune-based protection for SARS-CoV-2 should ideally extend towards 2 years and even more up to 3 years. And that means once a majority of us have gotten that protection, the virus will have to go away because it would not find a new host to be able to infect them. So just like SARS-CoV-1 and MERS-CoV, this virus will have to actually disappear as well. So this was a very exciting study. So let's look at it. I'm going to share my screen. Shelly, welcome. Welcome to everyone. All right, so let's start. So first of all, this used to excite me all the time. Jan Rosen, who is my friend from Sweden, he's an American now, he used to tell me that, hey, the name Greenland is actually sort of the opposite because Greenland is more icy, and the name Iceland is also opposite because it is more green. So here is a little article here which says that the glaciers cover approximately 11% of Iceland compared to 80% of Greenland. And then how did the Iceland's name became Iceland? So I hope I can pronounce his name correctly, Rafna Floki. So he was the one. Iceland got its name when a Viking named Rafna Floki ran up a mountain, saw a fjord full of icebergs, and called the country Iceland. And just for my fandom for Floki, this is modern day Floki. Remember, he worked in Vikings as a Floki. I loved his acting. So anyways, that is one. Secondly, here is the original study. The study is spread of SARS-CoV-2 in the Icelandic population. From this study, here is another article as well, which says humoral immune response to SARS-CoV-2 in Iceland. And then there is another article based on that study's data that says the power of antibody-based surveillance. So the basic purpose of this article is to show that the community surveillance, if you want to understand how many people have become infected and are infected or have recovered, then they say that a better test is antibody test compared to the RT-PCR. Although I think we all know as cool beans here that RT-PCR may be positive early on, will be positive early on. However, antibodies may start becoming developed from 7 to 14 days. So for that 7 to 14 days, there may not be antibodies, but RT-PCR may be positive. However, in this study, they're showing that if you take a large section of the population, and if you want to see how many people have become infected, then antibody testing is better than PCR testing because PCR testing is transient. It is for smaller period of time. So in this data, there is also the discussion of how long the antibodies stay and what kind of antibodies are there, which I think is very, very important. It proves our point that the immunity stays for a longer period of time. So let's look at it. So here is the study. And once again, Welcome, everybody. So here in Iceland, the population is 364,134. This is 2020, I believe. 15% of the population was tested in this study. So 30,000 people were tested. So that is a large swath of people that were tested. What they found out in the study was that infected people were 0.9%, and the infection fatality rate is 0.3%. And I would once again say that we have talked about it a few days ago. Infection fatality rate is a different number compared to case fatality rate. Case fatality rate is the number of deaths out of confirmed cases. Doesn't matter if the testing was more or testing was less. Out of the confirmed cases, the rate of death is the case fatality rate. Infection fatality rate is the actual number that we always look towards to try to find it, and that is number of deaths out of the actual number of people who are infected. So when we look at a larger swath of population, and then from there we can assess the population infected, then we can kind of approximate or reach infection fatality rate. So this is what they found out: 0.3% is infection fatality rate. That means everyone who is infected, we can find out they're infected or not, doesn't matter. Out of everyone who is infected, 0.3% is the death rate there. In Iceland, I just looked at Johns Hopkins. Also, actually, I looked at the Worldometer, and their data today, this is September 1st, 2,116 cases and 10 deaths. So back here, before we continue, last time some folks liked the painting. So this is another of my painting, which I had actually done. This is a digital painting. I did this on iPad with Apple Pencil. And here is a question for all of you as well. Which cool bean do you like more? So there are a few cool bean ideas. This is cool bean number 1. This cool bean has horns. This cool bean does not have horns. This is a really simple bean. This actually is Reddit-like mascot. So maybe it doesn't look good to have a Reddit-like mascot. And here is another cool bean. So which cool bean, number 1, 2, 3, 4, or 5, which one would you like? So tell me in the comments. So back here, my painting, and then back here. Now let's look at this study. So what they did was, in this study, or in this data that they collected, they had 30,000 people. The data was unbiased. That means they didn't try to pick up people in the hospitals or people in the household or people in a specific community. They just took 30,000 people randomly. These were from hospitals or in the communities or in the household from where they may have been exposed or infected. So that is a large swath, pretty good data. What they did was, then they tested them with PCR and antibodies. And they continued testing them for 4 months. So the data here, the durability they could show was over 4 months. Previous studies that we have discussed as well, which really caused a lot of news cycles that the antibodies are decaying and the immunity is not permanent and it is going to go away and we are now doomed. That study was for 29 days. And in this discussion today, I would explain, as the article explains as well, why they saw a declining antibody and why a longer period of time when you surveil the community, you would not see that kind of a decline. So we'll explain that. So they had done a PCR plus antibody for 4 months. Previous studies had done the antibody testing and monitoring for 28 days. What they found was, and this is what is the crux of their conclusion in this article, what they found was that 56% of seropositive were also PCR positive. So if you take 100 people who are seropositive, that means they have antibodies. Out of them, only 56% showed PCR positive as well. That means if we were only measuring or testing the PCR we would have left the remaining 44% who had recovered or were infected and were in the antibody phase. Their point of this discussion is antibody surveillance is a better surveillance compared to PCR surveillance at community level. So I hope that that is conveyed. What they also found, which was very interesting, was 1/3 of the people they tested and that were positive were asymptomatic. So that is also very interesting. And they also found that the infection fatality rate was 0.3%. We talked about it. Now, this is an interesting other observation they had, and that was in older individuals and hospitalized patients, antibody levels were high. Antibody titers, or the amount of antibodies in their blood, were high compared to women and smokers. This is my depiction of somebody who's smoking. So smoking a cigarette, not smoking. So lower antibody levels in women and in smokers. And also this, that in women, the symptoms were mild as well. And this is very interesting that we've been talking about it, that people with the milder symptoms possibly have the T helper 1 pathway of cytotoxic T cells engaged as well. And that actually helps them so much that it causes milder symptoms and they can overcome the disease faster. So this was another observation, and here is the explanation for why antibodies, both studies, how they are correct and why we should be able to say that the antibody protection will be longer. The basic crux I want to keep conveying today is that immunity to SARS-CoV-2, once developed, will be longer lasting. So here is what is happening. What they said was that, look, when the infection occurs in us, we know that first RT-PCR becomes positive because the nasal area and oropharyngeal area has the virus in it. Then within 7 to 14 days, antibodies production will start as well. And we have done this discussion in the past that IgM and IgG both start getting produced simultaneously or almost near to each other. Normally what happens is in other infections, usually, so let's say the infection occurs here, day 0, then 7 to 14 days, between 7 to 14 days, antibody production starts. And first IgM starts and then it declines, IgM, and then IgG starts after some times and then it continues, IgG. In case of SARS-CoV-2, we have seen that the antibody production starts within the same 7 to 14 days. However, IgM and IgG, they start simultaneously. So somebody had asked me this question, that why do they start simultaneously? And the excuse me, answer is very simple. SARS-CoV-2 it causes such a rapid progress that I believe cytokines, remember if this is a B cell and this B cell starts making, let's say we pour IL-4 and IL-5 on it, interleukin 4 and 5. Remember the remaining pathway, that my dendritic cell and the naive T cell that goes to the T helper 2 cell, and then T helper 2 cell releases IL-4 and 5 that is poured over the B cells, they become active. This IL-4 causes class switching. IL-5 causes proliferation of the cells. And I think that in case of SARS-CoV-2, the amount of IL-4 and 5 is so much, or the amount of cytokines are so much, that the B cells very quickly class switch and they go from IgM to IgG stage very rapidly. And because of that, there is simultaneous secretion of these two. Now, in here, what they're saying is a very interesting phenomena. What they're saying is this. They're saying that in the beginning, when the B cells start forming and they start producing antibodies, so let's say these are the antibodies they're producing. These B cells that are produced in the beginning are a lot in number. They're proliferated. There are tons of B cells, but they are also short-lived. So if we only depended upon these B cells, they will produce IgG and IgM for maybe a month, and then they would start declining. However, we know that there are memory cells, and we know that there are other B cells that would just continue that function of producing antibodies. So what happens is, somewhere over here, a new category of B cell becomes active, which are more persistent in their behavior, less in number. Less in number. So you can call them more prolonged serving B cells. They may be memory cells as well, but they are transited from acute to chronic type of B cells. So now what they're doing is they're going to start producing IgM and IgGs, mostly IgGs over here. And that IgG production by these cells will be more on the basal level, and it would decay very, very minor, in a very minor amount. This is going to then persist for long period of time. And what they're saying is that previous studies, when they only went for, let's say, 29 days, in that 29 days, they caught the antibodies produced by the transient initial B cells, which would produce a rapid rise, and then they would decline fast as well and go away. But because the study was only done for 29 days, it did not have a chance to look at the next set of B cells that would come in and then at a basal level continue to produce antibodies. And this production of antibodies is almost constant. It decays very less. And because of this, immunity would stay for a very long period of time. So if I now go back here to this one, and they have this diagram here as well. Let me just very quickly show you this diagram. So if you see this diagram here, this is the initial rise in antibodies, and then there is a drop. So what happens is that initial rise is by the more number of aggressive B cells that are producing tons of antibodies. So that is the first stage. They call it wave 1. And then the wave 2, which is more persistent but low level of antibodies, is by another set of cells that come afterwards. Now, the question that is this low level of antibodies enough for protection? I think that nobody can test that, because exposing a person again or challenging a person again with SARS-CoV-2 is sort of unethical. So we would just hope that this second set of cells are producing enough antibody that they are able to neutralize and take care of the situation. So back here, when you do testing, and let's say you are within the 29 days of testing, you might end up seeing a fast rise, or you might end up seeing a rapid decline. But if you go beyond 29 days, then you would see another set of antibodies that are not declining fast, that would continue on for longer period of time. So this is the most important thing to take away. This, I believe, so of course they say that we did this surveillance for four months. So all we can promise is that we know that for 4 months, the antibodies will be there. My conjecture, my hypothesis based on previous SARS-CoV-1 and MERS-CoV and coronaviruses and the immunity books, this and the studies that I have actually discussed before, this can actually stay in a more robust level for 2 years, and then another decline appears after 2 years, which finishes at the end of 3 years, where they felt, so this is SARS-CoV-1 study, where they felt that the level of antibodies was not sufficient enough to take care of the infection. So that means a possibility of reinfection would occur after 2 years to 3 years. So again, this flies in the face of a continuous discussion nowadays, again in the media cycle, that we have one reinfection in Hong Kong, and then there is another news that there is a reinfection here in the US as well. So out of 25 million people, is it possible for a couple of people to have reinfection? Do they have some immune system issues or testing issues, or there are some other things? Maybe. But at least here you can see that for 4 months antibodies are present. I would say that they would stay on for longer period of time as well. It's a good news. So the conclusion that they said antibody assays are better than PCR for the population level surveillance. For example, if you want to open up schools or communities or businesses, and you want to see what is the prevalence of the disease in that community, and what is the herd immunity levels and so on, antibodies is better than PCR. Although I would say it again, we cool beans have been discussing this, that it is not just the antibody, it is also the innate arm that we cannot measure. It is also the cytotoxic T cells that we cannot measure, and they all together form the actual protection that is given to different individuals in the society. And finally, Mubeen's own point here, yea, we were correct that immunity lasts longer. So this is the discussion. I know that I was going to talk about phagocytosis, but I went in this route. I would request you, I put this in the description as well. I would request you to give these studies and articles a look. And one more thing I did was I have put a link in this description of my paintings on YouTube. So if you wanted to, for your viewing pleasure, you can see them. So a couple of questions and then we'll break. And once again, I'm going to plan for phagocytosis tomorrow for the inflammation. I hope that we can do that tomorrow. So Melody says, yay, Jeffrey, Dr. Bean should get paid more, but money does not help morals, it corrupts them more. So Melody, are you saying that I should stop getting paid? Acoustic theory, I will refuse anything that's mandatory. Sorry, that is Carolyn RN. I will pay him more than I can. Thank you. So I like your paintings. Do you like Child Hassam? I haven't seen Child Hassam. Maybe please share that link. Acoustic theory, they'll say have fun more. Perfect. So I hope everybody is doing good. I hope you're all. I am actually very proud of one thing, and that is the level of depth that we have developed. These discussions have become so much easier for us, and it is we are on a more solid ground compared to many of the other folks who I continue to see that they are confused or they are sometimes worried or nervous. We should keep ourselves safe. Somebody put a comment yesterday when I talked about the discussion yesterday, which I did, in which I called the infection a nuisance, and they said, why, how dare you call it a nuisance? It is an evil, and that is correct. In many countries, it is now just going down to the level of nuisance, but for sure in the US, we are stuck. Just like that with Brazil and many other countries, that they are unfortunately not in a good state. So I totally believe that it is we are in a bad situation, but let's keep our fingers crossed. Please don't let your guard down. We are reaching the end. I believe in it because of the way, look at all the countries, just start looking at the countries and look at their death rate. Don't look at their case rates. Look at their death rates and then look at their whole population and then see that if the death rate as originally was seen with the confirmed cases of 3%, the death rate is never near 3%. And you see that the number of deaths are going down. What is causing that? Yes, people have become more careful. Yes, we started wearing masks and social distancing. Yes, R0 has dropped because of that. Maybe there is a weak virus. Maybe there is immunity levels that are increasing by antibody immunity, T cell immunity, innate immunity. So all of those are working together. And Sweden is the best case because I think the concept of second wave is not true for them because they kept themselves open. So if you look at their data and the death rates are plummeting, how did they reach herd immunity? From the plummeting death rate, we can infer that they are reaching a point of herd immunity. And if herd immunity means 60% or 50% of the people have become able to mount a defense, then how are they mounting a defense if their antibodies are only 10 to 12%? What about the rest of 40%? I am sure that they have other defenses plus masks or staying away, and all those things are combined. So we are going to reach that point very soon. Again, for US, I live here and I see that there is a lot of issues here. So don't send me fire about US. I hope we did better here too. So cool. So this is where we are at. And we will meet each other tomorrow. Hopefully tomorrow we'll discuss phagocytosis and inflammation. So thank you very much, guys. Stay safe and healthy, and I'll see you tomorrow.